Hi and welcome. My name is Colleen Schinderle and I am a second-year medical student at EVMS. My research is entitled A Comparison of Anesthesia Recovery Times After Initiating a Standardized Sleep Endoscopy Protocol. Drug-induced sleep endoscopy, or DISE, is a procedure used to study patients while sleeping, such as in obstructive sleep apnea. Evaluation of the upper airway is difficult during natural sleep, and so in DISE, light anesthesia is used to closely replicate it. A flexible fiber optic laryngoscope is then passed into the pharynx through the nose to evaluate treatment options. Prior to March 2021, CHKD had no standard anesthesia protocol for DISE, with sevoflurane and propofol being the most common agents used. In March of 2021, a standard protocol was implemented for children under 13 based on a statement from the American Academy of Otolaryngology. This new protocol involves administration of IV dexmedetomidine, an alpha-2 adrenoceptor agonist, and a sequential dosed amount. This drug has a slower metabolism than other comparable sedatives, leading to concerns that it may lead to longer wake-up times post-DISE. This study is a preliminary investigation evaluating the impact of the new protocol on recovery time and the post-anesthesia care unit, or PACU. We hypothesized that there would be no significant time increase. We conducted a retrospective chart review of patients at CHKD below the age of 13 who underwent DISE between March 2020, before the protocol was implemented, and after March 2021, after it was implemented. This was performed using PowerChart, CHKD's electronic medical record system, querying the CPT codes for nasal endoscopy, flexible laryngoscopy, and drug-induced sleep endoscopy. For each patient, information collected included age at the time of DISE, sex, race, any comorbidities, and how much time was spent in the PACU. These recovery times were descriptively analyzed using both median and interquartile range, or IQR. During the chart review, 1,405 total patients were identified. 58 met inclusion criteria. Of those 58, 29 underwent DISE pre-protocol implementation, and 29 underwent DISE post-protocol. The patient population was similar for its male-to-female ratio, but not for age or race. Of the 58 patients under age 13 that underwent DISE between March 2020 and March 2022, we identified two subgroups. 9 patients in the first subgroup underwent exclusively DISE. The second subgroup, containing 49 subjects, had DISE plus another airway procedure, such as a tonsillectomy, performed concurrently. We first looked at median time spent in the PACU for all patients, divided into pre- and post-protocol cohorts. This time to discharge was identical when comparing all patients at 59 minutes. Using IQR, we investigated differences between pre- and post-protocol patients, further subdividing them into the DISE and DISE airway groups. The DISE-only post-protocol group spent 90 less minutes in the PACU than their pre-protocol counterparts. DISE airway spent 5 less minutes. However, when all patients were taken together, the calculated IQR for the post-protocol group was 4 minutes longer than the pre-protocol group. Overall, we found that the median time spent in the PACU was identical for all patients pre- and post-protocol, while for all patients, the IQR showed marginally increased time. IQR was chosen as a statistical measure because it informs about the spread of the middle 50% of the data, resisting extreme values. As more patient information was added from DISE only with 9 patients to DISE airway with 49 to all 58 patients, the differences in IQR changed significantly, meaning that as we added more patient information intending to prevent skew, the more time was spent in the PACU with a new standardized protocol. Increases in PACU time for these patients could translate to negative consequences in terms of increased costs and congested OR schedules. Medical literature suggests that our calculated 4-minute increase based on IQR could equate to an additional $52 per patient. Limitations of this study include its retrospective nature. For example, we were unable to verify the reliability of documentation for anesthesia medications. We also used a relatively small sample size, given that only a year's worth of post-protocol data was available. In the future, we hope to further investigate with a prospective study utilizing calculated sample sizes, controlled anesthesia protocol, and the elimination of variability with concurrent procedures. It would also be beneficial to include future study into the consequences of increased PACU time on costs and staffing to streamline post-DISE recovery. In conclusion, this preliminary analysis of post-DISE PACU time shows that post-protocol patients may spend increased time recovering in the PACU. Further study will be necessary to fully elucidate the impact that the new standardized dexmedetomidine protocol has had. Depending on those results, further investigation should also be conducted to inform PACU practices. That concludes my presentation on anesthesia recovery times after initiating a standardized sleep endoscopy protocol. Thank you for your time and your interest.